Olá, bem-vindos a mais um SBQ Talk, podcast oficial da Sociedade Brasileira de Quadril. Eu me chamo Eduardo Machado e vou entrevistar o professor Thorsten Gehrke. Professor, como todos conhecem, é uma sumidade na ortopedia, é um profundo conhecedor, pesquisador e cirurgião especializado mais profundamente em cirurgias de infecção articulares, em próteses de quadril e todas as articulações. Professor, it's a pleasure to be with you here. I saw your class in the morning and you said that 1.5 revision stage started as a joke, but nowadays quotation from everybody around the world. So can you explain us the concept about 1.5 stage?
Yeah, first of all, thank you very much to give me the chance to explain something here about the 1.5 stage exchange, because it was originally really intended like a joke, because I just wanted to introduce a new spacer concept in case of two-stage exchange in our hospital. So just to create a funny title, I have chosen 1.5 stage instead of one stage or two stage. So the concept is quite clear. It is intended not as a one stage or a 1.5 stage. It's intended as a two-stage exchange. The only difference to the normal standard two-stage exchange is that you put in the first stage a functional spacer where the patient can walk on it with full weight bearing without any restrictions for a longer time than the standard interval, like 6 weeks. He can even walk on them 6 months and in some cases 1 year.
And what about the criteria? There is a selection for the patient for indication about that?
So we do it just in hips. In knees, we do a static spacer or something else. But in hips, our selection criteria is just the indication for a two-stage exchange. Right. In the meantime, we use this kind of spacer in any kind of two-stage exchange with different lengths of the interval. Some of them we are re-implanting after 6 weeks, some of them after 6 months.
Right. And what about the manage of soft tissue problems or big bone loss problems? How you deal with that?
It's a very good question, because this is our main issue if we are performing a septic, an infection surgery. Because due to the radical debridement, we have a huge amount of bone loss, and not only bone loss, as you mentioned, also soft tissue. This leads to the fact that if you do a thoroughly debridement, you lose stability. And this is the biggest advantage of our spacer and our 1.5 stage concept. Our spacer is in the acetabulum filled up with a dual mobility inlay. And that means the chance to dislocate due to the instable situation or the weak soft tissue is quite low. So by using this kind of spacer, you reduce the risk of dislocation.
Right. And the bone loss, for instance, like in acetabulum, you fill up just with cement, right?
Yeah. At the moment, there's no other chance. You have to fill up just with cement.
Okay. And what about the follow-up of these patients? Do you have like markers to decide when you're going to change and do the final revision?
This is still unsolved issue. When is the optimal time point to re-implant, right? So our decision is mainly made of the clinical symptoms. If the wound looks good, if the patient is quite pain-free, if we do not have any swelling, any redness, erythema, and the CRP level is constantly going down. It must not necessarily going down to a normal value, but it must be on the way to this. So, and then we are planning the reimplantation. So mainly driven by clinical signs and the tendency of the CRP value.
Right. And this whole time, this period, you keep with antibiotics, right?
Usually we give antibiotics systemically, IV, for 2 weeks, and then we switch to orals.
Okay.
Orals between 6 and 12 weeks.
And what about the results till now?
Our results with this spacer, with this functional spacer 1.5 stage exchange spacer are quite good, especially regarding dislocation rate. Our dislocation rate is about 4%. We did, in the meantime, 250 cases. Dislocation rate is quite low. Usually the dislocation rate of a spacer is high.
Yes.
And so it's just 4%. And the success rate, the infection control rate, is about 95%. So the concept seems to be not too bad.
Right. And what about the future? What are you going to think about what we needed to shape the 1.5 as a procedure, as a gold standard?
No, I don't think so. So the gold standard, more and more worldwide, there is a switch from 2-stage exchange as a gold standard to 1-stage exchange as a gold standard. There's a trend in US, very clear trend in Europe, in China. More and more surgeons are going into the 1-stage exchange.
Right.
Again, the 1.5 stage exchange is nothing else as a 2-stage exchange, just with a longer interval in between and with a special spacer.
And a better solution for the patient to move around and can be a good quality of life, right?
Exactly. So my projection for the future is that the 2-stage exchange for the next 10, 15 years will be still the golden standard, but more and more surgeons are changing into the 1-stage exchange. So I think in 5 years, more than 50% of the surgeons worldwide are using the 1-stage exchange.
And why you think about it? What make the doctors, surgeon try to now get more courage to change for 1-stage procedure?
Because our knowledge is increasing, our knowledge regarding the antibiotics, regarding the bacteria, our diagnostical tools are becoming better. The molecular diagnostic tools are coming up, like next-gen sequencing. So we have more options to diagnose the infection or to detect the bacteria. And if you know the bacteria, then you can do a 1-stage. And I mean, a 1-stage is for everybody better because it's just one surgery. For the patient, it's better, for the hospital, for the surgeon, and for the economics as well. So it's by far the better solution if it is successful. And the success rate of a 1-stage are, in the meantime, better than the 2-stage exchange. So that's is very encouraging. But now, this is my take-home message. It's only becoming true when you are specialized, when you are a well-trained, skilled surgeon who is specializing on this kind of complication in septic surgery. It's not a surgery for a surgeon who does just 4 or 5 a year. He must do at least 50 to 100. Yeah.
As you told in your class, it's like a tumor surgeon, right? You have to be very specialized.
Yeah.
Okay. Thank you very much for our talk. It was a pleasure, Professor.
Thank you very much. Thank you very much.